Lisa. I'll be co-hosting Airing Addiction with Lisa Blanchard.
No one story is the same as someone else's. Everybody's journey is different.
Thing on the table.
Having run substance use treatment programs for over 20 years, trying to make sure that we are welcoming to all. I love the idea that kind of having that exposure and that affirming place, even for one person, impacts that milieu, which then can impact maybe the broader recovery community, the community at large. I mean, I really love that thought.
Everyone, welcome back to another episode of Airing Addiction. Today, Lisa and I have some amazing guests with us. I'll let her introduce them, but we'll be engaging in some conversation today about stigma and, more importantly, about ending the stigma and negativity in this space that we're all in. So I'll turn it over to my guest, my co-host, Lisa Blanchard, and she'll introduce our guest for today. Lisa?
Thanks so much, Cathy, and welcome everybody to today's episode. I'm really excited to have this conversation, but I'm also really excited to have our guests with us. And so today we have Dr. Komaromy from the Graken Center for Addiction at Boston Medical Center, and Julie Burns, the president and CEO of RIZE, Massachusetts. So thank you both so much for joining us.
So glad to be here.
And so we'll get started by asking, Miriam, a little bit about what's the work that you do at the Graken Center and at Boston Medical Center to treat addiction and treat substance use disorder.
Sure. The Graken Center is a little bit of an unusual entity. We're essentially an umbrella organization over all of the wonderful clinical programs focused on substance use disorder addiction at Boston Medical Center. So under our umbrella, we have programs focused on treatment, such as our OBAT program, a program for adolescents and young adults called Catalyst, a program for individuals who have substance use disorders and serious mental illness called Above, a Respect program for pregnant people who have substance use disorders, and on and on. And our role is really to try to integrate all those wonderful programs and make the programs patient-centered so that we have a system that really meets patients' needs and helps them get to where they need to go within Boston Medical Center. We're also involved in a lot of other issues around education focused on addiction, policy and advocacy and research. But within the clinical arena, primarily, we're trying to just help everybody work well together and center around the needs of our patients.
That's such wonderful work and lots of really fantastic programs, right, with really specialized needs, but integrated into medical care. And that's one of the things that really impresses me about your services. And I've had a lot of connection with the education portion too, right? I think that's relevant to our conversation. The TA portion of Boston Medical Center, actually right now, Spectrum is doing a shared initiative for opiate treatment providers on providing really kind of important kind of clinical, presentations and trainings. And I think that, that Boston Medical Center has been a big piece of kind of spreading training, kind of across both Massachusetts, but also nationally, right? Starting to get some national reach to just provide technical assistance and help so that, more individuals are comfortable treating addiction, starting practices or enhancing existing practices. And I think that has a lot to support kind of reducing stigma and spreading recovery as well.
Absolutely. I think, addiction specialists can't possibly meet the needs of our entire population. And a lot of our goal and mission has to be to support folks working in primary care settings and primary mental health settings to, figure out how to do this in a really provide high quality care and care that is not stigmatizing, that's welcoming to the patient and helps folks engage in the treatment that they need in order to flourish.
So no matter where they are, they can access kind of high quality, evidence-based care.
Right, exactly.
Excellent. And so just to kind of give some introduction, I'd like to shift to Julie. Can you tell us a little bit about the mission of RIZE?
Sure. And thank you for having me today. RIZE is a statewide nonprofit. We were created in 2017, I think the same year as the Graken Center. So we are close collaborators with them and appreciate all the work they do. But we're slightly different. So we don't actually provide services. What we do is we raise funds to support programs all across the state, programs that are showing great promise and have the potential for scaling and replication. And we do that through sort of traditional grant making. We also generate and disseminate knowledge. So we fund research and then do lots of convenings to bring people together to learn about that research and help inform the field. And, you know, our goal is really to make sure that people suffering from OUD have access to care, non-stigmatizing care, quality care, as Miriam said, and better quality of life.
Fantastic. And so I love that we have kind of this discussion around, you know, recovery and language and stigma is going to be a big portion of what we talk about today. And we've got some treatment side of it. So both with, you know, Boston Medical Center and Spectrum, but also kind of representing kind of just how do we support kind of all pathways to recovery. And so I think that's a great kind of introduction. If you wouldn't mind telling us a little bit about the Together in Recovery initiative.
Yeah, I think this is one of the true gems that has come out of RIZE. You know, as we were putting together our board of directors and our strategic framework for the first couple of years that we were up and running, you know, we really did bump up against this issue of different philosophies and different opinions about pathways to treatment. We were seeing it in grassroots conversations. We were seeing it playing out right in our own boardroom, where we have people on our board from hospitals, from payers, people who are advocates, people who have lived experience. And it was just kind of always bubbling up, like, should we be focusing on, you know, medical or medications? Should we be thinking more about abstinence? And then we kind of started to say, why do we have to pick one? I mean, why is it one against the other? Why can't it be both, or person-centered, or whatever best for the person? So we came up with this initiative. It's a statewide initiative we launched in 2019, where we went around the state and did a number of conversations and really just talked to people. And to be honest, we thought the conflict was going to be a little bit more than what we found. But what we learned is that people just really want to talk to each other. They want to hear about other approaches, other ideas, other pathways. And there were so many times when people were operating in the same community, but didn't know the range of services that were available, either in partnership or collaboration, or they could refer somebody. So it's just been this really, really interesting project. And I think one of the great things about it, it has been governed by what we call the change team, which was about 40-ish people from all across the continuum, faith, law enforcement, people with lived experience, clinical, you name it. We sort of invited people to be at the table, and Lisa was on the change team with us, and we very much appreciated her input. And it's just really turned into this wonderful network of people, and they've stayed together. We're now in what we call phase 2, and they've identified some very specific projects they want to work on, and reducing stigma is one of them, as well as making sure that people understand the rights and protections they have when they're seeking treatment.
And I can't say enough about how wonderful that experience was, you know, not just to come in and share, you know, what Spectrum's perspective or my perspective might be on treatment, but to listen to all pathways and all opportunities, and just have good conversations that we're all really working towards the same goal of helping people achieve and sustain long-term recovery in whatever way they choose, right? And that's who's at the center, is the individual that's working towards recovery, and not kind of, you know, a plan that somebody else has created for them. And so it's really been a great conversation, and I'm glad to still be part of the group. And so I also want to talk a little bit about, because I do think it's something that has been spread both through the RIZE initiatives, but also, you know, across treatment providers. And, you know, I don't know if you could talk a little bit about the Words Matter pledge that Boston Medical Center started.
Yeah, I think it's a really powerful symbol of the way that Boston Medical Center has kind of across the organization embraced an approach to try to destigmatize addiction and addiction treatment. So the Words Matter pledge is a pledge that our CEO, Kate Walsh, sent out to every employee in our organization and asked people to sign it. And it's a pledge to avoid stigmatizing language, use person first language, use welcoming approaches to folks who have issues with substances. And I think it's really had a pretty profound effect in our organization. It means that everybody has heard from the top of the organization that this is something that we value, this is an expectation, and that we're expecting all of the BMC employees to come together around this. And it's one of the things that I get the most questions about from folks from other organizations who are interested in doing something similar.
Yeah, that brings me to the question of when we're talking about that type of language, and we go from saying addict to substance use, however we say, how do we determine that language, and where does that sort of, like, in your organization, I understand the pledge to absolutely be person-centric, and I love it as a person in recovery myself. It's just beautiful. It makes me feel less judged, I guess. And so I just wonder, well, how do we determine this, and how do we get the word out? Is it sort of, how do we get the word out?
That's a great question, Catherine. I think that these things, typically we start sort of in our own backyards with trying to change culture and try out different approaches to shift people's use of language and people's attitudes. And then over time, I think that we can, once we've kind of tried our homegrown approach and come up with approaches that seem to work, then we can disseminate it and spread it. And I think that the answer to how you do that is manyfold. I don't think there's any one answer. I think things like this podcast are one way of doing that, that you're sort of gathering together useful approaches and ideas and letting the world know about them. But, that's social media, organizational websites, webinars, asking organizations focused on addiction-related issues to endorse practices and approaches. I think all of those are examples. I think that's what we do as individuals that has the biggest impact. If we're using that language consistently in everywhere that we're interacting with others, it has a big effect, including our patient interactions, our interactions with our own patients. It's incredibly important and has its own set of challenges for how to do that. So I think it's a great question.
And at Spectrum and New England Recovery Center, we've been focused on reducing stigma for a long time. It's obviously a big part of our mission. We've been doing this for over 50 years, and we've done a lot of the work around being a recovery-oriented system of care, and that I think has prompted a lot of language, trainings. And so this is something we've grabbed on for a long time, but we actually specifically started implementing the Words Matter pledge because I liked the approach of asking all of your staff to take a pledge. Right. And so why we created, you've done a nice job putting it together. And so just also to let you know that, I run all of our clinical training. So all new clinical staff at all levels across all of our programs nationally join now virtually. So one of the benefits of virtual, right? And one of the first things that we do in that training is go over, recovery-oriented systems of care, go over kind of recovery language, and ask everybody to take the pledge. And so they all have to, virtual, right? It's a little bit challenging. So they all have to chat right in to the training, like I pledge that words matter with their name. And so it's kind of a, just a
virtual written pledge.
virtual pledge, right? I actually have them type it right out there. And so, I just want to, thank Boston Medical Center for kind of putting that out there, because I think it is just an easy way to spread that, right? Back to Cathy's question, like, how do we do this? And then putting out, so on your website, we have similar materials for our staff. kind of having, a list of kind of just examples too of what stigmatizing language is and what alternatives might be, right? Because you can't just say, you can't say this, because most often people are well-meaning and they don't know that there's a stigma associated with that word or that term. We need to give, alternatives. So how do we do that? And so can we talk a little bit about kind of what kinds of language might be stigmatizing?
Or what we can use instead. I like that. Yeah, this is a good starting point. Yeah,
absolutely. So, this is something that shifts over time, right? There are sort of trends and more sort of societally appropriate choices that shift over time. I think one big shift has been around person first language, and that's not just in the addiction arena. When I was in training, it was very common to say, "Oh, the diabetic in bed 3," even sometimes the MI, meaning heart attack, in room 4, and that's become less and less acceptable in clinical conversation. And now it's the person who has this, the gentleman who has diabetes, who has substance use disorder, who has opioid use disorder. So sort of just through that subtle shift, emphasizing that this person is not the same as their condition or disease, that those are two separate things. And this person has an existence and a self, definition and meaning that's completely separate from that disease. So that's one powerful little shift in approach. So really trying to start with person first instead of condition or disease first. And
I love that. Something. Yeah. I was trying to grasp what you meant by person first. Now I totally get it. This person has a condition, right. But what I really love about hearing you say that is it absolutely defines it as a disease versus a moral issue. This person has diabetes. They're not eating donuts because, you're not. It's a completely different situation. And I love how you just said that, because it's not a moral issue. You've defined it now. It's a medical condition.
Yep.
You wouldn't.
Yeah, it's often really helpful to look at the parallels between the way that we talk about other medical conditions and the way that we talk about substance use disorders or substance related problems. Because if they're really different approaches, you have to say, well, why? Why are we using a whole different framework in talking about substance use disorder that doesn't lead with it being a disease. So I think I use that over and over again to sort of scope out ways that we may have remaining issues with stigmatizing language and the way that we think about substance use disorders.
Yeah. And if I could just jump in and add, I think there's so much potential and there's been so much progress about changing language and changing perceptions. Because if you think about the way people with substance use disorder have been referred to in the past, it really did correlate to less than adequate treatment, right? So if you walk into a treatment site and you're called an abuser, there's plenty of evidence that shows you're going to be treated very differently than somebody who just ate too many donuts as a diabetic. So the difference, the impact of the language is so big. And I think now that people are really starting to get the hang of it, and somebody said, it's sometimes people just don't even notice, or they don't even know the impact of their words. And that's why things like the Words Matter pledge are so important. And another point I just want to share is there's also a lot of work going on outside the clinical space. The AP Style Guide, which is the Associated Press Style Guide, which guides the media, has a chapter on substance use disorder. I don't believe it's trickled down the way it should to reporters, but there is some work being done. There are a number of websites or tools out there to help change the narrative. Because again, when people see what we sometimes call disaster porn, the media likes to show the worst of the worst. It's hard to have hope, or it's hard to think that you can have any impact on this epidemic. So I think we have to think about the broader community when we're thinking about reducing stigma.
Yeah, and I think Lisa and I touched on this previously when we were chatting offline. But something that I think is interesting is, as you know, I'm a woman in recovery. I've been in recovery. I attend 12-step meetings. And one of the things that we find fascinating is the way people in various groups label themselves. So, hey, I'm an alcoholic. Oh, really? Great. But maybe saying I'm a woman in recovery is like, and I've noticed since these conversations and since working in the field in the outreach capacity, I've noticed I want to correct people and say, no, you're not a drunk. Like, what are you talking about? Like, let's change it. So there's some training that needs to be had somewhat with among the groups themselves that are helping people.
Yeah.
I love the fact that you also mentioned that at BMC, it's everyone at the corporation. It's not just the substance use division, and it's not just the doctors. It's the receptionists. It's everybody changing their language so that, I mean, I'm sure there's a population of people who work there that are also in recovery of some sort, and they can change it about themselves. I mean, that's how I hear it. Like, I need to be the voice for people in recovery also. I'm not, that moral issue is, I can change it one person at a time. Like, I hear great strength in what you're saying. It's just, it feels so much kinder.
That's great. I love your shifting that around from I'm an alcoholic to I'm a woman in recovery. I think that's really, really, really profound to assert that kind of self-definition. And you're right. It speaks to a need for culture change within some of the peer support organizations. I often struggle with this when I have a patient walk into my office who is saying, I've been an addict for 20 years. I'm an addict. I'm an addict. I'm an addict. And, of course, to be respectful, I'm not going to say, don't talk like that. But somehow we need to kind of get there in the course of the conversation. And I'll talk about, how I think about substance use disorders as chronic diseases of the brain. And that, I'll just sort of gently introduce the idea that, your definition is not this disease. And there are ways to talk about yourself and your condition that can help you to start to emphasize that to yourself and to other people.
Mm-hmm. And when I do trainings, I'll often, draw a lot of parallels to chronic disease and do some self-disclosure, right? So I have asthma. Like, what I would frame as like not a very well managed asthmatic, right? Like, I don't do all the things that I'm supposed to do. I don't take my controller medications, but I don't get labeled, right? When I go in, even when I go into the, doctor's office and my breathing is not great, right? And I have to go on prednisone again. Nobody kind of, stigmatizes me for that, right? And nobody labels me in any way, when that happens. But it's a chronic lung disease, very similar to a chronic brain disease, with actually some really similar, relapse rates, right? When you look at data. And so I often will kind of use that example because, diabetes is used a lot, and I love that example too. But, I think that people really don't think about other chronic conditions and how vastly different they're treated in, treatment spaces, in social spaces. Like, nobody's saying, Lisa, don't go for a run. What do you think you're doing with your lungs? You can't do that, and so I use that quite a bit in trainings with that I do with, communities, professionals kind of at all levels. And it seems to resonate a bit. So I really appreciate that perspective.
Here's one stigma that I come up against, and I'm just wondering how you might address that. And it's similar to, like, if someone's a diabetic and they need to take insulin, they don't say, oh, the doctors are prescribing the insulin because they were going to make a lot of money on it. But when it comes to things that will treat substance use disorder, they go, oh, they're never going to get off of that. It's all about the money. And I'm thinking, okay, well, heart disease, you're on Medicaid. Nobody's saying get off of the antidepressants because the Prozac invented, so how do you overcome that sort of stigma of thinking you're just getting trapped into the cycle so that people can make money?
Yeah, I think it's you sort of have the answer to that right in your the way you framed the question. I think, Cathy, that as you were pointing out, there, the pharmaceutical companies that make high-end medications for cardiac disorders make a fortune off of them, but it's not. We don't think, oh, they're just doing that to keep this person on this medication for the rest of their life so they can make money. We think, how fantastic, they've made something that can actually prolong someone's life when they have heart failure. And it's very parallel, right? That, I have lots of problems with and issues with the way that pharmaceutical companies operate in our country, but man, they have done so much good with the medications that they've produced. And the same is true in the field of treatment of substance use disorder, that there's just no question that the medications that we have approved to treat opioid use disorder, for instance, are saving millions of lives over time and improving quality of life and people's social functioning, professional functioning, et cetera. So I don't think there's any more reason to accuse those manufacturers of that.
I love hearing that, hearing that this is what we're doing. We're saving lives, we're prolonging, we're quality of life, and I think, Julie, correct me if I'm wrong, but that's part of what RIZE does, is promote the fact that all of these aspects are saving life. I mean,
they're tools in the toolkit. Yeah, and Cathy, I think that another interesting piece of this conversation is there is so much stigma around medication, being on medication for opioid use disorder, period. And Lisa, to your point, you do take medication, I would imagine, for your asthma, but nobody says you're on medication for asthma, or that's not like a thing, but within substance use disorder, it's a label, it's another label that's placed on people. And then there's a whole layer of stigma that comes with it. So I think normalizing or providing, evidence-based information that says, yes, medication works, it's effective. There's no doubt about it. There's plenty of studies and high quality literature that shows all of these things work, yet people are labeled and then stigmatized within their community, but also in other places. There are programs that, legally can't throw you out or not let you in because you're on medication, but we all realistically it happens. And that's just a really unfortunate thing. When, as Miriam said, these drugs are saving lives.
Right.
And I love the shift that the field is making towards moving away from medication-assisted treatment to medications for opiate use disorder or alcohol use disorder, because, it has that stigma associated that this is you're doing medication-assisted treatment because you can't do it on your own, right? And that there's something wrong with you, instead of it being a valid evidence-based treatment that could be part of your treatment plan and can change depending on where you're at, what your needs are, what your preferences are, and support your recovery plan versus kind of, you need this, it's almost like a crutch, it feels like, when you refer to it as, medication assisted treatment, and it can create some bias and dividing between kind of the recovery pathway camps, right?
Yeah, I think you're absolutely right on, Lisa, that the implication of medication-assisted treatment is that there's real treatment and then there's this assistance on the side that's the medication, and that's just not accurate. I mean, when we look at the numbers, the effect of medications is incredibly powerful, and everybody has to pick their own path. I absolutely support a lot of different pathways to trying to cope with a substance use disorder, but it's really important for us to acknowledge the immense impact of medications in some substance use disorders.
Yeah. Absolutely. And it also, I think, is that idea that it could be temporary, right? So you need temporary assistance, kind of like if you were to need crutches, right, temporarily. And so I think that stigmatizes longer term use of medications as part of someone's recovery plan, and that's often That's probably one of the biggest questions I get when I talk about in communities or I train on recovery pathways and options and treatment options is, why are you still in this treatment? Why do you still need this support after a year, 2 years, or many years, right? And nobody asks that question. I've been on inhalers since
That's right. You pull out your inhaler.
I agree. No one's saying speaking from personal experience, no one's saying you've been on that antidepressant too long, your mental health is doing really great, you better get off of it. Like, that doesn't come up. It's like, why would you? It's like the heart disease analogy. My dad has heart disease. He's currently in the hospital. And the point is, they're not going to say, well, okay, he's all good, let's take him off of that. Just like you're not going to take me off of a medication, or you're not going to take her off her asthma medicine because she's in remission from not having an asthma attack. Like, I think they're all really good analogies in the sense that I also laugh, or I think to myself, people they're getting into recovery to live a healthier life. When you're living a healthier life, when you're living unhealthy, I don't know if that's a good analogy or not, but when I was drinking, you could give me anything and I would say, okay, pop this, do this. But then why is it such a bad, the stigma becomes, oh, I can't take medication. It's like, are you kidding me? You were so sick that you would do anything, but now you're healthy and you won't do the healthy thing. That's the thing. I think if we could just embrace the fact that this is the healthy way of living, this is not, I guess I just have so much respect for how you're changing it. And Lisa mentioned the medication for opioid use disorder. Are there others that are coming along, terminology of that way that we could sort of speak of right now?
Another example along the lines of what Julie was referring to, the acronym MAT or MAT has been used for a long time, meaning medication assisted treatment, but people have proposed and are using it, the same acronym, but having it mean something different. So medication for addiction treatment rather than medication assisted treatment is a common approach that I think Dr. Sarah Wakeman, the medical director for RIZE, has really championed. She's a major force in the anti-stigma work in our field. She's published a lot on ways to reduce stigma and address stigma. So I really appreciate her work.
Yeah, I
love that.
Absolutely. And I think that education of kind of, you can say the same acronym. It's a little easier to say, right? So I even know myself training, that you can't say you can't shorten, medication for opioid use disorder. You can in text, but you can't really verbally. Right. So sometimes that can just, make it challenging to say it out every time. And so if we can shift the way that we view what, MAT might mean, then that might be a helpful way to be able to use that. So one of the other languages that I personally have a very strong reaction to, and do a lot of work with clinical staff and even individuals that we work with by just rephrasing, so that we're starting to model that language, is talking about toxicology screens and about patterns of use as not clean or dirty. That really sticks with me quite a bit. It really just has such negative connotations to it that if you are experiencing symptoms of substance use disorder, then you are dirty. And if you are having a period with less symptoms and not currently using, then you're clean. I mean, it's really, I don't think there's any more clear example of stigmatizing language than that.
I am with you. That's one that I have been fighting my whole career. And it unfortunately remains fairly prevalent when I work with people across the country, with clinicians, and honestly with my patients. It's part of that internalized stigma that people who have substance use disorders carry around with them. They hear these messages all day long from society, and they become internalized as a form of self-criticism and even self-hatred that's really damaging for people. So I love it, Lisa, that you're you're focusing on that. I think I agree. If we could pick one thing that we would wave a magic wand and remove that from the clinical lexicon, the terms clean and dirty are really
And what would the change be for that? Negative or positive or?
Exactly. Or some people have proposed using expected versus not expected. You know, the after our conversation, I got your urine test results and it wasn't what the expected result based on our conversation. Can we talk about it? Or and you're right, positive or negative, normal or abnormal are also acceptable. You know, they contain some of that pejorative feeling as well.
Yeah, and even the shift in the recovery treatment field to be less focused on results of toxicology screens as a definition of how someone is doing and what their status in the program is, right? It's just a piece of clinical information. It's helpful information to gather for monitoring, right? For safety, for if somebody is on medications, for medication adjustment, for treatment plan, potential recommendations to an individual. But it's only a piece of what we should, as treating professionals, be looking at. Right. It's only just one small piece of information.
Absolutely. I think a useful framework is to think about the ways in which we have traditionally, in treating addiction, we have had an approach of kicking someone out if they have symptoms of their disease. Basically, if someone has evidence that they've used and they're in a treatment program, hey, they're there because they have a problem with a substance disorder.
Agree. I totally agree. That right there says it all. You're trying to treat them.
Yep.
That's beautiful.
Yeah. One other thing I thought I might just toss into the mix is intersectionality issues. So that stigma related to substance use disorder plays out differently depending on who the person is who has the substance use disorder. For instance, someone who's pregnant is going to be treated very differently. Someone who is a person of color is going to be treated very differently. People who live in certain neighborhoods are going to be treated differently. And I think these are really complicating issues that we need to grapple with when we try to think about how to destigmatize our language. And not just our language, but our imagery. Think about advertising, think about media portrayals of people with addiction. There are just so many layers in which our depiction of an approach to a substance use disorder is affected by other factors, other characteristics of that person and how we perceive them.
Yeah, Miriam, I was going to mention something along those lines. I mean, I think one of the most egregious labels that we see or hear a lot are, addicted babies, or babies being born addicted, which is just simply incorrect. And the stigma that the mothers deal with, is just, I can't imagine. I can't imagine being a mom, having a baby, and being labeled that way, and then treated so poorly when trying to get help. I think that if there's something that really needs to be corrected, it's that level of misinformation that's out there about that.
And on our podcast not long ago, we had Teresa Harmon on, who works for To the Moon and Back, and supports, parents who have had children, either their own children or adopted or fostered, with neonatal abstinence, and not, and really working on kind of providing support there, and so that's such an important piece, because the stigma, especially for a parent, right, is unbelievable, and it can really perpetuate the cycle of addiction, right? So that internalized stigma can really just continue that cycle, especially when we factor in things like trauma histories, and and really our treatment environments can be re-traumatizing to people.
Mm-hmm.
And can push people to do things that aren't in their best interests or the interests of their unborn baby. That I see patients who say, "Oh, my family absolutely, doesn't want me to think about medications while I'm pregnant, medications for my opioid use disorder, because that would be bad for the baby. Not acknowledging the incredible risk for the developing fetus of having untreated opioid use disorder. It's really clear that medication treatment is the standard of care during pregnancy for people who have opioid use disorder. And yet there's tremendous pressure from society and peers, and often from the patient themselves, to not go that route because of the stigma.
I think it's so fascinating, and you brought that up. I love that, because I think you called it the intersectionality,
yeah.
Intersectionality. And I think that's an amazing thing. I'm wondering, before we get close to asking our final question, did you have any other things that we might have missed that would have been really pertinent to this conversation? I love that one, because I feel like we could do a whole episode on that alone. That's very timely as well in this day and age. But Julie, anything you'd like us to cover?
Yeah, I think one element that's important to think about is harm reduction, and how that's stigmatized, and how there's sort of a lack of understanding of what it is and what it means for people who are using harm reduction interventions as a way to, stay healthy to some degree, but stay alive in some cases. And the stigma that surrounds that it's, enabling, or it's, just not helping, or that type of thing. I think there's a lot of work that can be done to help people understand what harm reduction is and what it does. I mean, if you think back, seatbelts are harm reduction, sunscreen is harm reduction, bike helmets are harm reduction. But yet when people hear, needle exchange or syringe exchange, they go to a completely different place in a negative way, where they would say, yeah, seatbelts make sense. We should wear seatbelts to keep people safe. So I think there's a lot of work that can be done around that, because especially in a time where we have such increased isolation, harm reduction is a really, really important thing that we should be promoting, not sort of trying to downplay.
I love that. I think that would be a whole campaign. Seatbelts, sunscreen, what you just said. People are still driving fast and speeding.
Right.
But we're reducing the harm if they were to get in it. I love that.
Yeah, thank you, Julie, for bringing that up. I think it's a big focus for the Graken Center, and I think it's a critical area where we talk about stigma. Wow. But it's clearly life-saving interventions. So I really appreciate you mentioning that.
And one of the trainings that we're actually, doing, I think within the next few weeks with Spectrum and in Boston Medical Center, is on harm reduction and that approach, and even educating treatment providers, right? That I think that's just as important, about the value of harm reduction, and it really keeps, I think, that person-centered approach. So if you talk to, I've been doing a lot of work lately with syringe service programs in several states, and it's really, their perspective is just so person focused, right? It's just so individualized. And I think we could all stand to kind of, pull a little bit of that in, right? Of just my only goal here is to meet you exactly where you were at and keep you safe, at the same time as instilling hope. And providing options that you can choose from, right? And in viewing recovery as that kind of broader definition, and infusing hope into that recovery, I think helps that harm reduction conversation, right? Because the goal is to just keep people safe until they have a pathway that works for them to enter long-term recovery in however they define recovery, right?
That's beautiful.
Yeah, I think
Lisa.
it's finding a pathway and a relationship, which is also about reducing stigma, because so many people who are, getting their services from harm reduction or sort of more grassroots type situations often are unwilling to go into a brick and mortar site or a more formalized treatment setting. And I think, and a lot of it's because of stigma. So if, these relationships can be built, there's some trust that can be built. And then I think you lead to behavior change and a sort of more hopeful outlook on things.
Yeah, Fantastic. This has been such a wonderful conversation. I really appreciate you both for the work that you do, but also for being here and having this conversation with us and sharing this out to the broader world. So, Cathy, do you want to take on our last question that we ask of our podcast
Well,
guests?
yeah, we usually, since we get to know you during this 45 minutes, we love to throw out there a question. What sort of podcast or book would you, what really excites you, either in the industry or just to get away from the industry? Something we like just on a personal nature. What is one of your favorite podcasts or books that you would sort of turn people to?
Julie, you want to start?
Yeah, I'll go. Yeah. I would say, I think a great book that I've read, it's not even that new, but it's something that stuck with me, is Educated by Tara Westover. It's just such a fascinating coming of age story about sort of a family situation in a part of the country, that I didn't understand or sort of had just no concept of, and how this young woman navigates that and goes on to do such great things. So I think it's just a really well-written, interesting, true story. And then I'll add a podcast that I've been listening to lately is Heather Cox Richardson, who's a historian, and she covers sort of current issues in a pretty unbiased, balanced way, and ties kind of everything that's happening in the news to its place in American history, or it's in context of American history. And I think it's just kind of interesting. And I like it because there's like the level of vitriol is like really low. She does Facebook Live posts where there's nobody screaming at each other, nobody's, labeling people. It's just kind of getting the facts out in a really nice, calm, interesting, helpful way.
These are great suggestions. Thank you. Yeah.
Yeah, and I my favorite podcast these days is the On Being podcast by Krista Tippett. She takes a very broad approach to sort of our spiritual lives, much broader than any religion, and it just has wonderful conversations with thought leaders and spiritual leaders about sort of the meaning of life and how do we survive these stressful times and find inner strength and resilience. She's quite wonderful. And then it's funny, what comes to mind for me when I think about a book related to addiction issues is one that was very formative for me early in my career, which is a novel by Abraham Verghese that was one of his very first novels, published in the late 90s, called The Tennis Partner. That's about his friendship with a young medical student who struggled with addiction and ultimately died of it. And it's a very compassionate, thoughtful approach to thinking about the disease of addiction and people's struggles.
Thank you. These are wonderful. Wonderful. This is one of always my favorite portion of the podcast. So I'll let Lisa close out, but I always find these so incredibly inspiring. So thank you guys both for being here.
Yes, and yeah, Cathy gets to add to her collection of books and podcasts every time we do the show, which is one of her definite goals. So it's just been so wonderful to have you here, and I would just leave us all with the thought of, if you can pay attention to your words as you're talking with people, to the audience here, and start to make that shift and start to recognize when language might be stigmatizing. I think that's one of the ways in which we really start to make changes, if we all are mindful and paying attention to what words we choose, what words we hear, and making changes. So thank you all.
Thank you so much.
Thank you so much. It was great to be here.
Thanks.